Well, welcome. We're delighted to have so many of our students, faculty, and staff, our Geneva neighbors here, folks that are listening via live stream, including your father, maybe?
Yes, I hope so.
Yeah? Well, that'd be good.
Hey, Dad.
Yeah. Also a Hobart graduate. Let's give out a shout out for his father. So Chris, welcome back. It's so nice to have you here. And so we thought we'd have a little conversation together and then kick it out to your good questions. So be thinking of really good questions for Chris. But we're so fortunate to have you here back on campus. You've been back for commencements, convocations. You've given thoughtful remarks on this campus. And as I said earlier to some students, we talk a lot here about our mission statement, which is to prepare students for a life of consequence. That's the phrase. That's the mission. And everyone has a different definition as to what is a life of consequence. Given Chris's work and the current work in and around important global health issues, and currently as director of the Duke Global Health Institute after 30 years at Johns Hopkins, the faculty there, and I think the inaugural Desmond Tutu professor there, right, of epidemiology. A distinguished career in medicine and running the International AIDS Society, but really at the front lines of major global health crises and continuing to this day. So we're very fortunate. Join me in welcoming Chris Beyrer back there. So I want to take a little bit of time for bio, just to kind of level set, because I find it interesting with people of note especially. So replay the tape to us. You were born in Switzerland, and your father was also a graduate of Hobart and William Smith. And then you wind up here as an undergraduate. What brought you here? We'll get into your undergraduate time here, but give us a little narrative. How your formation before you got to the shores of Seneca Lake.
Well, first of all, I hate to say, if my father is listening, that famously what he talks about is having partied too much at Hobart, and so having to go to medical school in Switzerland. And that's how that happened. But remarkably enough, he did it in German, which it's Schweizerdeutsch, which is quite a thing. But we grew up, my four sisters and I, on Long Island, and I went to public schools in New York. And at the time, they were, I think, pretty weak in what you would call sort of humanities, social sciences, history, art, very not strong at all, but very strong in math and science. And I had a really good math and science background. I was super interested in everything living. And my parents were very indulgent, so they allowed me to have, I raised guinea pigs, I had Old English sheepdogs, I had fish tanks, parakeets and canaries, and it was a bit of a beviary, really. And I was always interested in biology and in life sciences, but I also kind of thought I wanted to be a writer. And I was always interested in the writing aspects as well. And I think, my school experience was really that, like a lot of young people at that age, I was just interested in a lot of things. And I'd been to a big public high school, East Islip High School, with a graduating class of around 800. And I'd never had the experience of being in a smaller, more intimate place, and where there was really the possibility to do lots of different kinds of things. And so that's really how I ended up at Hobart. I felt like it was really the right, wonderful place for that kind of discipline. And I did do the sciences when I started here, in math, with the great Abigail Mosey. I don't know if anybody is from her vintage. She was my calculus teacher.
Right.
I loved her. but also, really was interested in the humanities and ended up as a history major,
Right.
taking a lot of classes with Suzanne McNally, my advisor, who's here, which is so wonderful.
Let's give it up for Professor McNally.
Yeah, indeed. And then, I had the experience my senior year at Hobart and William Smith. I spent the first 6 months of it in Sri Lanka with the Center for Foreign Service, and an island country off the coast of India. We were all supposed to go to India, actually. That was the plan. And then Indira Gandhi was assassinated,
right.
yeah, by her bodyguards, and suddenly the student visa thing became.
And that's how you get to Sri Lanka.
Yeah, very much by a swerve. But, and I was doing the project in medical anthropology. I thought that would also, I was super interested in that, with a wonderful faculty member here, who subsequently was a professor in New Zealand, Margaret Trawick, also known as Peggy Egnor. I don't know why she had two completely different names, but, but she was a really good medical anthropologist. And so what I did there was apprentice myself to two traditional medicine practitioners, two Ayurvedic doctors. And Sri Lanka had preserved a very old form of Ayurveda and a very original form, many believe closest to the original form of Buddhism as taught by the Buddha. So it was really an interesting place for me. And I started meditating there, which is a good or a bad habit, but I've been doing it for 40 odd years. And
Every day?
No, but I practice all the time. I practice every day.
What does that mean?
So, for example, when I'm going into my office every morning, I do Medicine Buddha invocation. I never speak at a public event like this without doing a meditation and an offering beforehand. And as we just did.
I was going to say.
Yeah. Public health, one of the aspects of Buddhist teaching is that there's inherent suffering in life. Nobody escapes from suffering. It's the first noble truth. There's suffering in life. But what public health really tries to do is reduce unnecessary suffering, right? Nobody should die of measles. You don't have to do that in our world. We have a safe and effective vaccine, right? Women shouldn't have to die in childbirth because the basics of healthcare are not available to them. And so that's our mission, is really achieving equity in global health and public health. And I feel that is deeply Buddhist.
Has that informed your journey?
Yeah.
Professionally?
Yeah, I think so. I try and use those teachings and practices as a manager, as a leader. I'll give you one example that in Buddhism, the idea of motivation is very fundamental. So actions can have positive outcomes, they can have negative outcomes. One's own motivation is very important in whether something will be successful or not. And so you have to check that all the time. You have to ask yourself, what is my real motivation here? Am I really pressing forward on this science, or am I worried about the grant funding? And the more true you are to the core motivation of reducing unnecessary suffering, the better the outcome.
I love that.
Yeah.
We'll get more to unnecessary suffering in current events.
We're having quite a lot of it.
Yes. But let's so you graduate from Hobart William Smith in 1981. You go to medical school, downstate.
Not right away.
Okay.
Yeah, no, I really wanted to, when you're on this little island of Sri Lanka, you kind of see India above you, writ large. And so I spent a good 2 years really kind of working, traveling on the road, really following that Buddhist path. I spent a lot of time in India and Nepal. And eventually I ended up in a Tibetan refugee camp. And I was volunteering there, kind of working there, and really encountering the Tibetan diaspora, people who'd been driven out of China and fled when His Holiness the Dalai Lama fled in 1959. And I realized at a certain point that I was having this extraordinary experience, and I was so enjoying every minute of it. and I was a kind of expensive mouth to feed, and I wasn't really helping anybody there. And I had a meditation teacher who was a very astute guy, and I would go and see him about once a week. And at the end of those meetings, he always said to me, "So when is it you're going back to go to medical school?" And I said, "I never said that." But eventually, it just became inevitable that I would do that. And I went back and happily went to SUNY Downstate, which is in East Flatbush, Brooklyn.
Right. But by the time you graduate, you go right out to the AIDS crisis in New York City.
Before I graduated.
Before, right.
Like
so,
the
right.
First
through
day
the
on
80s.
the wards, yeah.
And that crisis informed your medical interests in epidemiology and infectious disease.
Yeah, yeah. I remember, that when you're a medical student, if there are physicians in the room, you'll know this, that there are all these different kinds of rounds. You go on rounds with the residents, and then you go on rounds with the chief every once in a while, so that the chief of service happens maybe once a month. And this guy was a well-known infectious disease doctor, and he sort of picked me out of a group of 5 of us and said, "Okay, show me, let's go around and talk about each of your patients." I was following 9 patients, and 8 of them were people who had advanced AIDS, HIV/AIDS, and 1 had advanced AIDS and tuberculosis. Right? And at the end of it, he said to me, "You're not learning medicine. All you're learning about is HIV/AIDS." I said, "Look, I'm not picking these patients. I was on call, and this is who was admitted, and this is who is here." It was, without question, the epidemic of that time. Sure. It's still, we still have, we've had something like 42 million deaths. We have 37 million people still living with HIV worldwide. We got to almost 75% of all people living with HIV on therapy, which is one of the greatest achievements of global health of our time. I mean, it's just a magnificent achievement. A lot of that due to the generosity of the American people.
Mm-hmm. So when you look at all the work you've done in HIV/AIDS, and then obviously COVID most recently, 2 of the major global health problems, what should we be thinking about? What are the takeaways from that as we go forward? And I guess attendant to that is what concerns you with what's happening now in public health in the United States.
Well, I think the first thing to say is that the investments in research pay off unbelievably, and you have to be willing to make those investments. There was no comparable investment in biomedical research. There still isn't comparable to the U.S. until
U.S. government investment in largely universities.
That's right, and through the NIH. So, for example, when I finished my training, there were 2 antiviral drugs. There's lots of antibiotics for bacteria, but in terms of viruses, there were only 2 licensed drugs: Tamiflu, which is a lousy drug for flu, and acyclovir, which is a lousy drug for herpes. That's it.
Wow.
And because HIV is a virus and is a retrovirus, it really required looking at virology in a whole different way. We called it rational drug design. It meant understanding every step in the viral life cycle and then developing an antiviral agent to block each of those steps. And it took 800 clinical trials and 15 years and billions of dollars. But eventually, we got to safe and effective therapy. So HIV treatment now is 1 tablet once a day. Incredibly effective. You still have to take it for life. But that opened the door to a whole further generation of antivirals. So based on the HIV antivirals, we developed antivirals for hepatitis C, which was the worst kind of hepatitis to have. It used to be called non-A, non-B, It's entirely curable. 8 weeks of oral therapy once a day. Well tolerated, you're cured.
And the science joined to what you learned.
And when COVID emerged, it turned out that because we know so much about virology and so much about its life cycle, we very quickly developed 2 antiviral drugs. Warp speed. And the most effective antiviral, Paxlovid, one of those drugs is an HIV drug. It's a reverse transcriptase inhibitor. It's the same class. And so that's, that is super important. And, those antivirals, by the way, when President Trump got COVID and was desaturating in the White House and losing oxygen capacity, he was put on both broadly neutralizing antibody that came out of warp speed and the antiviral. So hugely benefited from the science.
But warp speed was a success for that administration.
It was a resounding scientific triumph of our time, yes. And full disclosure, I worked on the COVID vaccine trials. I still am a senior scientific liaison to the COVID vaccine prevention network. But yeah, it was unprecedented, really. And just to give you a feel, when we first had the first organizational call to talk about the trials for these candidate vaccines, Tony Fauci, of course, the head of NIAID at the time, put forward, we're going to have to do 5 efficacy trials, each one with 30,000 volunteers. So that's 150,000 American volunteers in the next 6 months. And we hadn't done 5 efficacy trials in HIV in 25 years.
Wow.
It was just incredible. And it's the only time in my whole career, I've been funded by the NIH for 33 years, which is a lot, uninterruptedly, which is not easy in this world. But it's the only time in my life that none of us had to write grants to do any of this. It literally was send us an email. How much of your time can we have? I said, we can have half my time. I'll give you 50%. And so I worked on all of those vaccine trials. And the American people, it was incredible. We set up a registry, a national registry, and we had over 1.6 million Americans step up and volunteer to be in those trials. As it turned out, we didn't need most of those people. But nevertheless, the timing was so extraordinary because what had happened was after the first SARS outbreak, which was 9 years before COVID, work had begun on these mRNA vaccines for coronaviruses, for the relatives of COVID. And the furthest along was one for another bat coronavirus that actually is a Middle Eastern respiratory syndrome. Which you have to have exposure to bats and camels. So probably nobody in this room, I'm guessing. There are no camel rider, herder people here, but it was a serious disease in the Middle East, right? And so that vaccine work was underway at the NIH. And the spike protein of COVID-19 and the spike protein of that other virus were really very, very close. Took 13 days to change the insert and insert the COVID-19. Once we had the sequence, January 6th we had the sequence, we had the candidate vaccine in 13 days. And then we had the mRNA vaccine approved by the FDA and ready to go November 23rd, right after the election.
2020, yeah.
Yeah, right.
When did you first have a sense that science was winning with COVID?
Well, the way these trials are done, the gold standard of clinical trials in people, in human beings, is the double-blind placebo-controlled trial. And the reason for that is that if nurses, physicians know who's getting the vaccine and who's getting placebo, or who's getting a drug, who's getting placebo, they tend to want, the sickest people to be protected. There's a lot of bias that can come into that. Or if they're uncertain about a vaccine or a drug, they may bias it in favor of the youngest, healthiest people getting it. We can't have that. The people administering the products can't know what's in the vial, right? And it's double-blinded because also the people making up, the only people who know are the study pharmacists, right? What is in it. The patients don't know, the providers don't know. And then there's a data safety and monitoring board that is looking at the data as it progresses, and they know, and they're seeing. But we can't break the code until they have signed off. So you don't know until the day the trial is stopped. And that I will never forget it, because I was at my dining room table in lockdown, like all of us. I was teaching from my laptop, doing all of this from my home in Baltimore.
You're at Johns Hopkins.
At Johns Hopkins, absolutely. And everybody's on the call. Fauci is presenting the data, and up comes the slide of what happened to the people who got placebo and what happened to the people who got vaccine. And it was 95% efficacy.
That's when you knew.
Yeah. I actually burst into tears.
Yeah.
I'll be honest with you.
You're at your dining room table.
I was so relieved. I just thought, okay, we're going to get out of this.
Yeah.
We're going to have a vaccine, and we're going to get out of this.
That's great.
Yeah.
So with all of that as background, so now we're in 2025, and you're at the leadership of an important global health institute.
Yeah.
In touch with policymakers and observing what we're all observing. What do you make of the current U.S. public health approach?
Yeah. Well, I don't want to be too negative for the students who are in the room, but what is happening right now is that the scientific infrastructure of this country is being gutted. And the reason for that is for most of us in the field, I think, is just simply unfathomable. The narrative about what the administration is saying and what RFK Jr. and the others are saying, the guy who now has just been named head of the National Institutes of Health, Bhattacharya from Stanford, what they are saying is that the COVID effort was a failure, that the NIH failed. RFK actually sued the Food and Drug Administration when we knew the vaccines were working, to say we shouldn't be using these vaccines, we should be using hydroxychloroquine, which is a malaria drug, and ivermectin, which is a deworming drug for animals, as treatment, right? And we'd already done those trials and showed that they had no efficacy. So we are weirdly inverting. I mean, why President Trump doesn't want to own the magnificent success of this scientific endeavor of warp speed is hard to imagine. But the people around him have embraced these ideas, and the leadership, the people who really made all of this happen, like Peter Marks, who was the director of vaccines at the FDA.
They recently resigned.
He was forced to resign.
He wrote quite a letter.
Yeah, well, we worked closely with him. He played really critical roles.
Explain his resignation.
So the FDA has multiple divisions, and the people who head up those divisions really have enormous scientific expertise. That's the job. So if you're, for example, in charge of antibiotics, you're looking at antibiotic resistance, at microbial stewardship, at a whole array of issues, new antibiotics. What antibiotics should we hold in reserve for, resistant bacteria, multi-drug resistance? Peter Marks was the head of CIBER, which is the Center for Vaccines and Biologics, and really just a great expert in this field. And he tried to work with RFK Jr. He tried to work with this new administration, as he had worked with multiple administrations before, and was rebuffed and felt that they actually were not at all open to a scientific discussion, that they had a existing set of ideas that they were determined to put forward, chief among them vaccine skepticism and hesitancy. So his resignation letter, it's going to go down in American history. You should read it, find it online if you haven't read it. Because he really spoke to how we are moving, this administration is moving in an anti-science direction as quickly as they can.
So when you say science is being gutted, meaning federal funding?
Yes. So
I worked for a president who I think doubled NIH.
Yes. Bill Clinton doubled the NIH budget. Yeah. So just to give you an example, Johns Hopkins, where I worked for 30 years before going to Duke, has had $800 million in funding cut. That is a huge, huge cut. Now, most of that, $500 million of that, was entirely for maternal child health programs in low and middle income countries.
So translate that to a JD, not a MD.
Yeah.
What does that mean? 800, it sounds like a lot of money, but what's a real world effect of that?
The real world effect of that is what we've been trying to do in global health with maternal child health is a couple of really basic interventions. So the first is you want every pregnant woman to have prenatal care, to have B12 and folate if they need that, to have regular checks. You want a skilled attendant at every birth. So somebody there who really knows how to deliver a baby, as opposed to a mother or a sister or somebody in a village with very little training. You want access to antibiotics, because one of the most common causes of postpartum death after delivery is sepsis. All right? Mm-hmm. So antibiotics, you want to be able to stop obstetric hemorrhage. That's the most common cause of death in women. That's handled with a very simple 1 or 2 drugs. So that basic toolkit and the people who are trained to deliver it have saved millions of lives. But that requires an infrastructure. Somebody has to train those people, the drugs have to be delivered, there's a supply chain, and that's what that money does. That's what it was doing. And in the most fragile countries, it plays a very central role in supporting health systems. So that's places like Democratic Republic of Congo, Sudan, South Sudan. There's a long list, Cote d'Ivoire, West Africa. In the better off countries, in the countries where there's more capacity, they were supporting more advanced kinds of interventions, like cesarean sections, surgery. But again, that requires training. Nurses, obstetric nurses have to be trained, midwives, physicians. And the US has been the single largest supporter of those programs. And it's made a huge difference in safe motherhood. Now, if you want to transition out of donor-driven or donor-supported aid, the usual time to move a program onto government ownership is about 10 years. Right? This was done over a 3-day weekend. Right? Just an abrupt cessation of all of that support. And that means that systems literally fall apart.
And people will
die. I'll just give you an example that the HIV program specifically was put on a 90-day pause. Now, you can't pause antiviral therapy. You have to take it every day. There's no such thing. It's like putting diabetes on a pause. Really? You think you can do that? That's not how it works. All right, so that 90-day pause was implemented. And then we worked with a great modeler at University of Washington. Over the next 12 months, what would the impact of that be? And a conservative estimate, we published it very quickly, was 100,000 excess deaths in the first 12 months and 135,000 perinatal transmissions, 135,000 babies born with HIV who did not need to be. And those are preventable infections. And that's underway. That is happening.
So we've read a lot about President Bush, 43, PEPFAR, and the success of that. What will that mean for the continent and beyond?
For those of you who don't know, PEPFAR, it's called the President's Emergency Plan for AIDS Relief, was really a visionary commitment that George W. Bush made in a State of the Union address in 2003. He announced that he was going to, it was actually on the eve of the invasion of Iraq. So it was a tense moment for the world, and he made this announcement that he was going to be funding a $15 billion program over the next 5 years, $3 billion a year, to address what was happening in Africa. And at the time, life expectancy was falling all over the continent. It had fallen, for example, in Zimbabwe by as much as 30 years. Right? That is an unbelievable decline in life expectancy. So it needed to be addressed by a major program. And when he announced it, I was sitting on the couch watching this with my husband at the time. I turned to him, I said, he's not going to do that. That money's not going to come. And it did. Yeah. And he did it. And it was spectacular. It was not easy to stand up, but eventually it became, over the next 21 years, the largest commitment to a single disease in history by any government. And we had, as of the time of the inauguration, 21 million people on antiviral therapy supported by this program, about 600,000 of them children. We had saved 25 million lives and prevented over 5 million perinatal infections. So really an extraordinary record of achievement. And it always had bipartisan support.
Right.
We had support across the aisle. I was on the advisory board for the program under President Obama, and then I was fired after in the first Trump administration, but then rehired by President Biden and continued, to work on that program. Last September, was when it was supposed to be reauthorized for another 5 years, and if you all remember, it was a time of extremely tense partisanship, and of course it was a presidential election year, and we ended up for the first time not getting a 5-year reauthorization. We got 1 year. And it just expired last week. It expired March 25th. So now it is not an authorized program.
And the consequence of something not being authorized
is that it can be killed.
And not appropriated.
And not appropriated, exactly. So right now, I'm sure many of you know, the US government is funded on a continuing resolution through September 30th, and that is still the Biden budget. It's still, that's the CR. But we're very, very concerned that it will not survive the next round of budget negotiations. And the problem there again is if you wanted to transition off, and we proposed, we published a 5-year plan for how you would do this.
Over time.
Over time, over 5 years, and with 3 tiers. So there are countries that are probably pretty close, like Rwanda is ready to transition. And there are others that in 5 years are still going to need help, like Malawi, a very impoverished country with a very high burden. But still, there's a rational way to do this, scientific way to do it, a humane way to do it. Abrupt cessation is, as I said, will lead to 100,000 deaths just in this next 12 months alone, and 135,000 babies born with HIV who don't need to be. And that is, it's a horrible disease, and it's preventable.
Yeah. One more question, and then let's kick it out to our audience here. But so much is in the news of vaccine hesitancy, information, misinformation. How do you think about that from kind of the public health communications of it? We have a sea of views, leadership changes with the secretary. What should we be thinking about? What should we be looking at?
It's interesting. So we make a distinction. I think it's a worthwhile distinction that disinformation is the deliberate spreading of falsehoods, right? The people who are engaging in it, for whatever reason, generally are aware that it is a falsehood and deliberately spread disinformation. Misinformation, which is much more widespread, is quite a different phenomenon. That is the unwitting sharing and onward sharing of information that is in fact not accurate. And lots of people engage in that. We looked at this empirically, and we published this last year in The Lancet. It's kind of the leading global health journal. Looking at the amount of exposure to misinformation and disinformation about COVID vaccines and mortality across the United States by county. We looked at every county in the United States and whether that county went for Trump or Biden. This was right during during that period. And it was very striking that there's a direct relationship between the amount of misinformation, disinformation people are exposed to and their likelihood of getting vaccinated, and of course, their likelihood of having bad COVID outcomes. And we were able to show a difference in mortality, which is not always so easy to do. So, I think the first thing you have to say is disinformation is lethal, particularly when it's disinformation about infectious diseases or other kinds of health threats. Now, when you look carefully at who was spreading that disinformation, it turned out that there were fewer than 20 people who accounted for 85% of it, of the disinformation about COVID vaccines. And most of those people were actually in a network connected with each other. Several of them were physicians. And one of them was Robert F. Kennedy Jr. He was a major, major source of disinformation. So the fact that he is now overseeing the whole of the Department of Health and Human Services should give us all cause for concern, right? HHS, after defense, is the biggest part of our government, right? It's Medicare, Medicaid, Social Security, the Food and Drug Administration, the National Institutes of Health, the FDA. It is the infrastructure of health, such as it is in this country. That is why I think those of us in the academic scientific community are really deeply concerned about the directions these people are going in, and also about the kinds of things that they want to reinvestigate. So we have had the science that the one paper that linked vaccines, the measles vaccine and MMR and autism, has been thoroughly debunked. It's been thoroughly investigated. There is no link. We're still trying to understand the etiology of autism spectrum disorder. It's not clear, but anyway, it's under investigation. But RFK Jr. has reopened that. He's commissioned a study. And the person he appointed to head it up was fined for practicing medicine without a license in my former state of Maryland, and is a complete unqualified vaccine skeptic. So what is he going to find? He's going to find this spurious link and going to further undermine, advanced vaccine hesitancy. And the reason that that's a problem is because we've seen it very clearly that when people are more hesitant, immunization rates go down.
Is this West Texas?
This is West Texas. And then vaccine-preventable diseases come back. And Kennedy has said things like, this is an individual choice. But that's not how public health works. It's not an individual choice, right? The way measles outbreaks work is you have to fall below a certain coverage rate in the population for measles to spread. And we're below that right now. We have fallen below. It's the most infectious respiratory virus there is, so you need very high coverage, over 95% coverage in children under 5. We're nowhere near there. In Texas, they're way below.
I could ask questions on that here, but I won't. Let's kick it out to the audience. I think we have some microphones to make sure we hear any questions here. Why don't we go right here, and then we'll go right there. I commend your sweatshirt, Red Sox. Thank you. We will definitely recognize you. Yeah.
So what would you say is the best way to combat dis and misinformation in an age where it spreads so rapidly and from sources like the government?
Now, there's a good, succinct question.
Yes, that is a new twist. It truly is a new twist. So I think, first of all, the empirical evidence is that if people are vaccine hesitant, the most effective approach is very local. It's their primary care providers if they have them. It's time spent understanding people's anxiety and where they're coming from. It's challenging to do, right? But in terms of the science and in terms of the evidence, this is getting more complicated right now, and it requires some sophistication. So I'll give you an example that Bhattacharya, the guy who's now the head of the National Institutes of Health, was one of the co-authors of something called the Great Barrington Declaration. And Great Barrington was the idea that we just hive off the elderly and vulnerable people in society and let COVID rip. And they published papers on this and said that there would be no more than 40,000 American deaths. Well, there were over 1 million, right? So they were slightly off on that. But they were then, really roundly sort of, I would say, disputed by the mainstream scientific community. So they formed their own academy. They have this thing called the Academy of Public Health. And they have 6 of them in it. They have a new journal of the Academy of Public Health. And when you look at the papers, they look like real papers. They actually look like real science. And if you just searched on the internet and put in, COVID and autism, bloop, these things will pop up and they will look like a scientific paper. And so it's going to require people to be more sophisticated about the scientific literature. And scientific literacy, has been falling in this country. One of the reasons why we're so delighted that Hobart and William Smith now is doing a public health major and minor. Yay. I think that is just really, really heartening. The disinformation is a little different because that you really have to get to the root of who those people are and what their motivation is. So, and it turns out that very often there is deliberate disinformation from people who wish us harm. The Russians, have been very involved in this. China was very involved in it. The Chinese, part of the Chinese disinformation campaign about mRNA and about the Mpox vaccine, for example, was that it had, ape DNA in it, which totally doesn't. Mpox actually is a rodent virus. But, that it was playing on those kinds of stereotypes and on those kinds of fears.
Good question.
Yeah.
We'll go right here. Just wait 1 minute for the mic. We'll be able to. Thank you.
Thank you. Hi. So what advice do you have for students trying to pursue a career in biotechnology, pharmaceuticals, public health, especially as we see these major policy changes threatening public health and science research?
Yeah. Well, first of all, I have to say, we are in an extraordinary kind of golden age of biomedical science. It really is extraordinary. And these policies and this period of difficulty and challenge is not going to be able to undermine that, right? It's going to be different, and it's going to look different. There are, for the next several years, almost certainly going to be many more jobs in the private sector than in the public sector, because the public sector is being radically downsized. But the scientific advances are just extraordinary, and the COVID vaccines is one example. The CRISPR technology is another. We are really working toward, and there is a lot more hope now than there's ever been for the idea of a cure for HIV. The Gates Foundation is funding a whole program area in what would essentially be a single dose of gene therapy. These potentials are really there. Without a cure and a vaccine, we're going to be treating HIV forever. And without the support to do that, we're very concerned that it's going to come back. But the advances are so exciting. In my view, it will not be able, and happily, there are some other players besides academia, and the Fed, principally pharma, but also others and foundations, who know this and who are investing in it in very big ways. I think you're also going to see, it'll be interesting for the next several years, a much more multipolar world. The US has dominated this space in a big way. I don't know why we've decided to cede our leadership, but for right now, that is what is happening. And that's going to be a big change. And, silver lining, it might be an exciting, innovative change. The woman who did a lot of the advances in mRNA and just got the Nobel Prize for it, she shared it with Drew Weissman at Penn, was an obscure Hungarian, really toiling in obscurity, and couldn't get NIH funding for her work.
So will funding leave universities and more to foundations or the private sector? I mean, research dollars?
I think, Mark, the way that we have funded the biomedical enterprise and the training and capacity building for that biomedical enterprise is through federal funding to research universities.
Right.
That's how it's worked. Right. That's the mechanism.
Johns Hopkins, that's...
Number one.
Right.
Number one. I think it's been a wildly successful model. It seems that higher ed is not a priority for this administration, quite the opposite. And that, going after, for example, some of the major universities that they have, like Hopkins, Harvard, Princeton, and the list is growing. Although, as the New York Times pointed out, all in blue states. All these universities that have been targeted for these massive cuts are in states that Trump lost.
But it's interesting because 100 years ago, the top 10 universities were not in the United States.
Yes.
Oxford, Cambridge, Sorbonne, Germany.
Yeah.
So in 100 years,
Yeah.
American universities have really
Yeah.
ascended. So it'll be interesting to see what the next, questions. Why don't we go right here? Thanks, Emma.
Yeah, so you've mentioned the shift from the public sector to the private sector. With the Trump administration, there's been lots of shifts from a federal or a big government stance to a state's government. And you've mentioned like pockets of blue states where these like top academic institutions are. Do you see these regions becoming hubs for maybe state-funded research for these sorts of things? And you see in New York, you have the SUNY schools and lots of SUNY medical programs. You have the UMass programs. In Berkeley, in California, you have the Cal programs. Do you see those becoming hot spots or like regions where people will flock to because maybe these states will allocate funding?
Well, that's a great question. And I think the answer is that yes, that's already been happening. So, and I'll give you an example from North Carolina, because that's where I am now based. More than 20 years ago, and sort of 30 to 20 years ago or so, the state of North Carolina realized that its future was not tobacco and timber, right? Which is really had been kind of the base. And they made a conscious decision as a state to invest in the knowledge economy and to create incentives, state incentives for companies coming. So the research triangle, which basically is UNC, Duke, Wake Forest, NC State, now has about 900 companies. It's the highest proportion of doctorally trained people in the United States. And we actually now are a bigger industry than timber, as we like to say. It seems incredible, but it's true. And California did the same, with Berkeley and Caltech and that whole area. And the largest one, of course, and really the first, is Boston, with the spin-offs from Harvard and MIT and the other universities. And in all three of those cases, the states played a big role, no question. The big pile of money is from the Fed, right? And it's hard to replace that. But the research universities in those areas, like UNC and Duke, are the anchors. They are the anchor institutions. And of course, that's also where people get the advanced training they need to lead in this space, right? And the states can make that also very favorable. What's happening now, for example, with the threats to medical universities in particular, is that there are medical schools in all 50 states. And in many of the poorer rural states, the far west and the deep south, which also happen to be the reddest states, typically only one or two, most of them are state schools. And they have all joined together. The AAMC, the American Association of Medical Colleges, has a suit against the government for these cuts. Right? And I think that that's really important, because we're going to need solidarity. The idea that we get more balkanized and that the states don't, each one becomes more distinct is actually going to be very bad for the poorer, low-income states. They, by the way, are also way more dependent on Medicaid, and the proposed cuts to Medicaid are going to have very big impacts. If what they propose goes through, certainly south of us, the South Carolinas, Georgias, Mississippis, Alabamas, they're going to have healthcare deserts. They just won't be able to sustain that.
Questions here? I go right there.
So I lead maternal and infant health programming nationally for the March of Dimes.
Oh, bless you.
Yeah. And as you know, data is a driving force on where we put programs
Yeah.
to reduce maternal and infant mortality. And so, as you said, sort of in the slash of a pen, we lost our entire CDC division that we work with to have that data. And we have a very robust perinatal data system at March of Dimes, but it's fed from PRAMS and natality
Right.
data and others. Do you have a suggestion about where we're going to be able, as a nation, to be able to continue to collect and disaggregate data in the future to help drive where we do programming?
That is a super important question, and it's broader than just that system, but obviously it's a critical one. They have, for example, with PEPFAR, they maintained life-saving therapy. That was the plan. It actually hasn't worked, but that was the plan. But completely stopped all funding for the monitoring, surveillance, and data systems. Just stopped that cold. And it's hard to see that it isn't, in a way, a little bit covering their tracks. But we are losing very quickly. In the last 3 months, we've lost a whole surveillance infrastructure to understand what is happening. That, I do think, is going to fall more and more on the states. And of course, the cuts to the state health departments, which were supported by CDC in many states, is another huge challenge. What you always hoped for in some ways is, and I will tell you that this came up in a really interesting way during COVID, because we don't have a national surveillance system, right? We have multiple state systems. For many, many years, we only had 37 states that reported on HIV. Remember that? So you just, couldn't ever figure out what was happening in this country. But countries like the UK that actually have a national health played a really important role in our understanding of COVID epidemiology, because everybody's in it and everybody in the hospital is on the same program. And you don't need the same kind of surveillance system that we've tried to stand up everywhere, because actually the healthcare system is the data system, right? That would be something like Medicare for all, right? If we were able to do that. But absent that, I think it's going to fall to the states. I just don't see how else it's going to be done for this stretch of time.
One last question. Yeah, I'll go back to you.
Do you think the privatization of all of these innovations and the push towards big pharma is going to limit the accessibility of the innovations made, especially for lower class people?
Yeah. So, the reality is that there's no getting around the fact that part of the role of government, of public health systems, of global health efforts is to try and address that inherent inequity, right? That the market is never going to do. So it's true for rare diseases. It's true for vaccines. There's not a lot of money in vaccines, and that's why we have a special system for vaccine development, because otherwise we wouldn't have vaccines. So there's no question that the drug companies have access programs. They try and do at the margins, address equity. But ultimately, the only way to do that is if you provide health benefits to the poor, right? And to marginalized communities. And by the way, to children. It's hard to tell an infant to pull themselves up by their bootstraps, it's not really how it works, right? So I think, it will still be that there's innovation, but we are already seeing a decline in equity and in access, and that's going to accelerate. The biggest advance in my field in HIV in many years is a new drug called lenacapavir. Anybody heard about that for HIV prevention? Yeah, okay, one or two of you. So lenacapavir is a long-acting injectable antiviral, and it is given twice a year. So 2 injections a year, 100% protection in women, and 97 or 98% protection in men from HIV infection. It is revolutionary. It's as close as we're going to get to a vaccine for the foreseeable future. And it's at the FDA right now, seeking approval. And the plan was that it was going to be implemented across Africa by PEPFAR. Absent PEPFAR, it's not going to get to Africa at all. So people with good private insurance in this country who have an indication for it are probably going to be able to get it. It's priced in the US. We don't know where the price point is going to be, but it's the other injectable that we have, which is 6 times a year, so it's an every 2-month injection, is $24,000 a year. So it's probably going to be priced in that range. And then again, people on Medicaid won't get it. We'll see. But it's an extraordinary innovation, and we were poised to roll it out. I called it, I just gave a plenary at the US HIV meeting and called it a revolution that may or may not happen.
So just to build on that, kind of just our last
Yeah.
question here, probably deference to your time, but when you look at environmental degradation and climate change,
Yeah.
so frequently affecting the most marginalized populations across the planet, where's the role of public health there?
Yeah.
In environmental, as a matter of equity, as a
Yeah.
matter of climate issues? How is the field thinking about it?
Well, where the last 2 COPs have been, the climate global meetings have been all about this issue of, you could phrase it in a lot of ways, but it's essentially reparations, helping the most affected and poorest countries become more climate resilient and adaptive, because virtually none of them have a carbon footprint and did anything to damage our climate. That has really been done by the wealthiest countries, the US, China, India, and Europe, Japan. And there was some traction there. There is a fund now. It's woefully underfunded. The asks were very large. I think the total climate resilient fund now is something like 400 million. I mean, it's nowhere near what's going to be required, to address this problem. But it absolutely is, it's sort of the next great social justice question of our time. And, where I just was in Kenya pretty recently, and we did a climate meeting in East Africa on these issues. We're doing a big program in climate change and global health at Duke that I've initiated, so I'm very in this. Some support from Rockefeller. And I'll just share with you that the last year, 2024 was the hottest year on record. And the hottest place on earth in 2024 was a part of northern Kenya called Turkana, which is a very low-lying, super hot area. It was 156 degrees there, which is outside the band of human evolution. We did not evolve in a climate that hot. And actually, one of the things that happens is that the placenta stops functioning. Placentas cannot function at that heat. So, those people are facing, really reproductive challenges because of heat. They're mostly nomads. They're pastoralists. They follow herds. They have 0 carbon footprint. And of course, it's not like there's air conditioning there. So that's a place where we're really trying to figure out what climate resilience is going to look like.
Well, give us a Buddhist inspiration going forward. How do you wake up? You know all these challenging places and dynamics around the world. What keeps you focused and inspired?
Well, I tell you, Mark, I feel as though whenever I'm out in the field and whenever I'm interacting with people in these places, that their optimism and their resilience, and of course, for the most part, they're the folks who are actually on the ground suffering, is so remarkable. And happily, one of the great things about being an academic is that there's this thing called the fountain of youth. Smart young people keep walking into your office and saying, I want to get involved in this work. I want to do this. And it's uplifting, and it keeps you sane. And I guess the last thing I would say is taking a lot of walks in the forest.
There you go.
You got to do that.
All right. Join me in thanking Chris Beyrer here. Thank you. Thank you so much.
I really enjoyed that.